Yeah, good morning everyone. So today we're gonna carry on with our discussion of health services and why we're all here for. Today's talk is on need, demand, and use. Now you may think you know all those three words really well. They're not hard, but actually there's more to it than initial thought. And actually we're all clinicians here, so actually it'd be really good to get all your perspective at the end as well about the systems in Japan and where you know it, countries you know it. So just to outline where we've thought through so far from the outline of the course. One of the structures we use in this course to lay out health services, I mentioned on Wednesday, as we look at it from inputs, processes, and outcomes perspective. So it's a nice structure. And we've already whirlwind through our way through our inputs, and we talked about formal and lay care, diseases and medical knowledge, and healthcare professionals as well, and also users of healthcare and the staff-patient interaction. And actually, yesterday's seminar we had a little bit more deeper dive about healthcare professionals and the users of healthcare, and you can see where it fits in the sort of grander scheme of health services and delivering health services. Hopefully, we're beginning to build a picture already of the micro, macro, meso levels of how health services are organized, and come to realize some of the complexities of it. We see it now that it has come to be, and what the challenges we're facing in trying to solve the many questions on quality, and different dimensions of quality, and we're looking at different aspects of a large puzzle and why it is the way it is. Hopefully we're now getting below the surface a little bit and we're getting a picture. So today we're going to carry on with processes and looking at need, demand, and use. So that's where we are. Okay, so we're going to start off with a conceptual model. And I don't need to teach grammar, you all know what models are. But basically, it's just for us to be mindful that it's a model. What we're going to share, is what's taught in the course, and what's in our textbook. It is a simplification of the realities of the world. But we know the systems and organization of healthcare services is complex. And we do require a model to help us explain the complexities of the world. And we're always working with models in science and also in our daily lives. Like, for example, we're really familiar with geographical models like a map. A map is a simplification of what the real world is. But without a map, we wouldn't be able to even start understanding and navigating things. So this is similar, and a conceptual model, similar in a similar sense. It's helping us to think about processes. So this is a helpful one to look at need, demand, and use for health services. Like I said, you might know all these three words, but it's actually not as obvious as you think. But it's also really crucial to lie to the heart of health services delivery, to understand what each of these are, and also the interrelationship between these. So hopefully this morning together, I'll take you through an overview of how we can think about each of these and how we can think of it together, and the model that relates it all. So I'm going to share with you two models this morning. But the first one is this. Okay, we have a population, and this is a group of people in a country, and if you magnify it, it could be you or me, and so we are a population, and if you look in the sort of more micro sense, one of those in the population becomes a patient, can be a patient, a member of the public. And at this point, suddenly you wake up this morning and you have a headache. Because of the summer's heat, you feel headachy. And then at that point, you have moved from the population to a felt need arrow. You have a felt need. You aren't doing anything with your headache, you just feel like you have a headache. It's a subjective thing. No one else knows about your headache, and no one else can qualify it. It's just you. So at this point, it's a felt need. Then you do one of two things really. Key step. You might turn your felt need into a demand. This is where you go, oh, I think I should check this out. This is odd. I'm not used to having headaches first thing in the morning. And you will go to either your pharmacist or your doctor. It might be one of those things, but those things, both of those, you would have moved yourself towards demand and that way. And you've turned your felt need into demand. Or you might be a stoic and think, I do not trust doctors. I do not trust painkillers. I don't want to do anything. I'm going to sleep it off. And it would just have gone to the felt need. You would not have done anything with the need. And that would not be demand. So once you've turned, and this we term illness behavior. And this, whether you do this or not, is purely down to the patient, down to the public. And it's a vital thing. We talked about lay care and formal care. And a vital thing because this illness behavior drives that cross between turning from lay care into formal care. So this is quite a crucial concept to remember. So felt need to demand. The next step is also very crucial. And that's called turning it from demand to normative need. And this is based on if you turn up to your doctor or your pharmacist and you say, I have a headache, doctor. The clinician can want to do one of two things and say, yeah, I think we should check you out. This is, I'm going to look at do an optimal scope and look at your fundus, and I think, I'm not sure, maybe we'll scan your head and something that we think is serious here, not normal headache. Or I say, you can sleep it off, it's nothing, it's nothing serious, don't worry. That's clinical judgment. And that can turn your need into a normative need, so a need for healthcare, objectively concluded by the doctor or the clinician to say, yes, you have a need for formal healthcare. That's not necessarily only the doctor's role. It could also be sometimes the pharmacist decides that. Say, well, yes, I'm going to give you a drug and you need this medication. Take this and you'll be better. That's also a formal normative need because a clinician has qualified your demand. Sometimes they will say, no, don't worry, take a rest, you'll be fine. And that will be a felt need. Now we might think this is clear cut because it's objective, but actually, I will further explain, but actually it's not. It varies. It varies, sometimes it's very obvious. If you have a broken leg, hopefully 100% of doctors will see your x-ray and say, well, no, that needs fixing, let's reduce it or something. Or it might be very subjective. It might be like, well, yeah, sleep it out and see, 2 days later, it's not better, come back. It might be sometimes not obvious. So there's a degree of variation in clinical judgment as well. That's also crucial. Then afterwards, we have a couple of things. Your need, so if the clinician has decided you have a normative need, there's one of two things that occurs. Your need is met immediately, where the doctor treats you or the pharmacist gives you a prescription and you have your need have been met, so you're in the most far right. Or there's a bit of this is what we call rationing. It's impossible for all health systems and healthcare services to meet all needs straight away. For example, waiting list is a form. So you might not be able to meet your need immediately. You still have a normative need. It's just not fixed immediately. It might be a bit of a wait. You should have a hip replacement. It doesn't look very good. However, be on this waiting list, and this can be long or short. Sometimes it's not a waiting list. Some rationing happens in healthcare because of pay, your ability to pay. So yeah, you can have this treatment, but you can pay for it. And if you can't pay, also you've gone into category of unmet need. So that's rationing. Now, if you are in unmet need, one of two things can happen. Your need can be met at some time point in the future, or it can go back to a felt need. It probably never be met. And eventually, your symptoms spontaneously resolve when you go back into the population and you no longer have a health need or a felt need. The last thing, just to point out also, that it's possible that you are in a healthy population, and we are school public health, so we think about populations, without a felt need. And this is where screening comes in, where you didn't know you had a need, but you actually have disease, and you screened it, and health prevention activities, you went for screening, and you detected some early cervical cancer, and so you suddenly have a disease and it becomes normatively straight away without your realization of having a felt need. This is the model. Hopefully, is a way of us understanding the way needs and demand and use come together. There is another model, which is also quite helpful, and this is by an Australian GP, sometimes in the 60s, called the clinical iceberg. It's quite famous in other, you probably have heard of it. So what he kind of clearly described is that there's only the top of the iceberg above the waterline, so to say, that you can see, which is demand for formal care. And that this iceberg gets bigger in the bottom. So majority of the population of us, hopefully, are healthy, and we have no need, demand, etc. for health care at all. And then there's this little chunk of the population where he called it unfelt need. So this is the people who would actually have disease, but you are not aware. So unless they went for screening, they wouldn't know. Then there's another chunk, which we covered, where there's felt need but no demand. So this is the person with a headache and haven't done anything about the headache. And then we've got demand for lay care, we talked about on Wednesday, where you seek some support and advice from friends and family, and then over the borderline, formal care. So this is also quite a classic and useful model. But can you imagine, we talked about on Wednesday, that all that demand for lay care, if that shifted to formal care, how that might shift the waterline and how much more demand for health services that would create. And we talked about changes in provision of lay care as well, as one of the challenges that we're facing today. Okay, so today we have 4 topics to consider really. We talked about need already, a little bit. Professional judgment, use, and does use reflect need? And these are all few quite crucial interrelationships. Hopefully our model has started to help us think a little bit about where things sit. First of all, we'll talk about need a little bit more. Need for health, just to recap, is a felt need, subjective. And in order to be able to understand it, there's no other way to get to it unless we do population self-assessment surveys and a bit of objective measure. Like you can send in clinicians to people's homes to observe people's mobility, for example, or you ask the patient to say, can you report how much you can walk? And often, clinicians take history purely to get the people's assessment of their health, of the needs for their health. So this is how we get evidence from epidemiological surveys. Okay, and the need for healthcare, normative need, is all of the above, plus a clinician knowing, this is crucial, knowing the knowledge of the appropriate use of care. So what if there is an effective treatment out there? So in places where there's no effective treatment, you don't know what's best to do, then there's no need for healthcare because there's nothing to solve that person's issue. There's also an understanding of cost effectiveness here. So, we might have osteoarthrosis or osteoarthritis, and you might see it very obviously in an X-ray. And the patient can be reporting symptoms like, I can't walk up the stairs anymore, doctor, and it's not very comfortable, I get a niggle. And the doctor says, yeah, you have osteoarthritis. But when does that turn into, yes, you should have a hip replacement. I think you should have one now. That's a risk benefit judgment, that's a cost effectiveness judgment. That's when is treatment better than no treatment? That's crucial. So that's why we say the above plus knowledge of appropriate care. We might think that's black and white, but actually for about 80% of healthcare, we actually don't know necessarily the cost effectiveness, let alone, but we don't know the effectiveness, let alone the cost effectiveness. So actually for most of care, it's actually dependent on a lot of things. Time and place, and clinical judgment, most of all. It's also dependent on understanding of the best treatments as well. So with new clinical guidelines and things. For example, so high-income countries, it varies between countries. So high-income countries, it is now shown to be most cost-effective and effective if you have a heart attack, time of your heart attack to a PCI center within 90 minutes. And that's exactly what you want. So it's most cost-effective if you have a heart attack to send them to a major center and get them into a catheterization lab to open up their blood vessels again within 90 minutes. Now that's expected in England. That we do that with our EMS services with our patients. Most cost-effective care has been shown, best for patients, and best for the health services. However, if I was in rural India, I wouldn't expect that. I shouldn't expect that same level. So it's dependent on how much you spend as a health system, health service, technology, and what is the understanding of the day in scientific evidence, and what is affordable. And that is dependent on the willingness to pay. Threshold is dependent on the value judgment the country puts in on health. So just to be mindful that these things are more complex and have a lot more than one meets the eye. So let's move on to some evidence and some studies that show this in context. What does it really mean? So this is a really interesting study that shows us the decision to screen for AAA, for abdominal aortic aneurysms, from America, UK, and US. So now, scientific evidence that underpins when you should screen or whether you should screen for AAA is the same. So these three countries use the same scientific literature. It's a multi-center country study. And can you see the variation in how the decisions are made to screen? So what they've decided to screen for AAA. Same evidence base, but for the UK, they decided to only screen men between the age of 65 to 74. And for Canada, they also decided to screen women above the age of 65. But UK, we don't screen women at all. And in the US, not only do they screen men between 60 to all the way to 85, women as well, and also men. So they've decided on quite different things and who to screen and who not to screen, based on the same literature resources, literature evidence base. So it reflects the decisions reflect what is most cost effective at the time. And now, me and you sitting here, we can't really decide who's right. Who's to say America's doing it best? Is Canada doing it best? They're doing, at least they're doing women too. Or is UK actually most cost effective because the evidence suggests that you should only screen men and actually all those women don't actually really need to be screened. So we can assume, but only, we can't really say who's right and what's wrong. Also, it reflects how much the country is willing to spend and the resources they want to put in. Okay, this is also very interesting, a slightly older study now, but this group have looked into grey literature and policy documents of different social insurance schemes. So all of these countries have a commonality: France, Switzerland, Germany, Luxembourg, Israel, Netherlands, and having a social insurance, and they provide standard packages of care. And they've looked at what is provided across all these countries. So there's some universal things. Then the interesting thing is they've also looked at some controversial treatments that only some countries provide and others don't. For example, some countries, so what's called controversial, it means that these 6 countries don't all provide dental care in their standard package of healthcare. So they don't think dental care is necessarily needed in there. But we might go, oh, interesting. something dental care should be included, should it not? There's a bit of debate. Germany is the only country that offered spa treatment, spa care. Now, I don't know if in Japan, whether spas, I know hot springs are very popular. Spa care, is that in a spa health? Should that be provided in a universal package of healthcare entitlement? But in England, if we thought about spas, we think about very luxurious. It's definitely not healthcare. But in Germany, that was at that time that was provided as part of the insurance scheme. So, whether it should be fundamental entitlement, these are really fixed. And this is probably a combination of behavioral beliefs about health, what a cultural country context perspective feel that is beneficial to healthcare, and the impacts, combination of those. We don't, sitting here, again, we can't really put a judgment on whether it's right or wrong. So it's quite interesting. There's two other types of need that we should actually be aware of. In the literature, we have something called relative need, which is when actually a lot of countries and a lot of places use a lot, because we don't actually know the need. We mentioned the difficulty in measuring need. We need to use population surveys and incidence and prevalence. So when we don't actually know the true need, we use our relative need, which is comparing with similar populations. And we are making some assumptions. We are trying to understand that one incidence and one prevalence in one population is similar. We also don't know exactly how effective a lot of the treatments are we mentioned. So how cost effective, how effective, maybe only about 20% of interventions. We know definitely that there has been health technology assessments more effective, cost effective studies. So that's why planners usually use a relative need. So, my neighboring city is doing this much, is seeing this much need. Yeah, I think that's probably the right amount of need. So what we do, what we offer, what we say is need, is a combination of all these different things: wisdom, experience, belief, cultural. There's nothing that's uniform in this. Similarly, sometimes some textbooks call some say express need, and that essentially is demand or normative need. They say express need is the demand for help. Okay, another important concept for us to talk about is professional judgment. And we already touched upon it through our conceptual models. But essentially, we know professional judgment varies. Not only does it vary between country, which we've already seen in AAA decision to screen or not to screen, but it also varies vastly over individuals. So 2 doctors might not make the same decisions. We often say, hear doctors say, I don't have a power to make any decisions anymore, the managers make it all. But actually, doctors do make quite key decisions. So the majority of the highest treatment costs, so whether or not you have a hip operation or not, no hip operation, does lie between the clinical judgment of the medical profession. Some limitations, but actually, the doctor is the one that decides to give you that hip replacement. But if you do decide to give you a hip replacement, it's $10,000, so it's quite a lot. Nurses can also make a decision. If you are a nurse and you decide to give a patient a very expensive dressing, silver line dressing, and you give all your patients silver dressings to help them have antibacterial benefits, that cost will be so much more different than if you decided not to give any silver dressings and just normal, the basic dressing. So it can actually have huge impacts. Other things that we know that professionals take to make decisions. We touched on this yesterday in our seminar. Professionals consider mainly three aspects: self-interest, patient's interest, and society's interest. As a clinician, not only if you're a doctor or a pharmacist, nurse, all clinicians do that in the health setting. And when it's mindful that we should look at self-interest, when we call it aspiration for income, enjoyment to work, and desire for approval from peers, I think it's important to consider all three of those aspects. And self-interest is not a negative thing, and only if the balance is tipped. It's not a derogatory term, and I think that's important to understand. If you had a doctor whose self-interest was so high that overrides society's interest, overrides patients' interest, that balance, when it goes wrong, can be very detrimental. But usually, when it's in check, there's no issue. As a patient, you obviously want your doctor to be purely in your own interest. But actually, as a good doctor, you probably want all those three things. You want the doctor to be not only thinking about the patient in front of them, but have a bit of perspective of society and the importance of resources used. So you can argue that a good doctor is having those three things in balance. Because we know that if you give one thing to a patient, someone else is not happy. So that's why those three perspectives. And these things are not fixed, and that's why there is a variation in differences there. So this is quite an interesting piece where The Guardian is a newspaper from England, and this is not a scientific study, but an article from journalism. So this is a journalist. He actually went around London, one area of London, and sort of investigated journalism and went to different. He took his mouth basically to 4 different dental practices, and he just went along and said, "What can you do for me?" And so he went to these 4 different dental practices, and they quoted him on the same day these different figures for work he needed for his mouth, his teeth. Can you see that the first one said, just a routine checkup, £32, this is some time ago, more expensive now, but all the way to the last one said, it's pretty bad. I think you need a lot of work, £915. And that's just one mouth, one day, 4 different services. Look at the variation in what they're offering. You might speculate the reasons why, but from here we don't know the reasons why. We don't know if Nigel Mayer is actually being, the right amount. That's the right amount of work he should have done, and actually Pickering just didn't want to have the hassle, or whether or not there's something going on there that actually somewhere in between is the right term. We don't know, but actually it's just interesting, isn't it, to see this variation. So thirdly, use. Now we can look at use in different ways, different perspectives. Mainly the measures of use are from two different perspectives, different ways of accounting for where the data comes from. Firstly is population-based, so where the individual population is counted. For example, we can have immunization coverages, emergency admissions for asthma, we count the number of people, that's population-based. Service-based is when we look at from one service or one area, the proportions to another. So GP referral rates, proportion of patients from an area admitted to a specialized center. So this is a different perspective we can look at use. So let's look at some examples of this. First of all, this is a service-based measure of use. So you look at the different general practitioners from Finland, and we're looking at how many are referred in per consultation to a service. And out of 1,000 consultations, some GPs make very little referrals to secondary care, and some make way more. This is about a 15-fold variation there. Why is that? Some family, this is generally, general practitioners. Some in just one country. Really, can disease really vary that much? Or is it some that are saying, well, are dealing with more of it. More experienced GPs are not referring, more inexperienced GPs are referring lots? Or is it the other way around? Some are more safe. We don't know if it's good or bad, but it is a 15-fold difference. It's quite dramatic there. This is another service-based example where we're looking at districts of the states. And this is about the ratio of using a branded version of drug outside patent or a generic version when the generic version is available. And you can see here, there's huge variation, isn't there? But this is probably a bit more obvious if you're looking at it from a healthcare perspective point of view. You probably want people to be using a lot more generic drugs and a lot less patented expensive drugs. But we can see how there's a lot less use of generic medicines in the South in the US. So what's going on there? Think about the big pharma we were talking about, the interactions there. Huge folds of variation. Oh, by the way, mindful, this is for Medicare in the States. So this is public. They're public over 65 years old, those drugs. So there is a federal interest in this because it's public money. So this is a different country, looking at England now. This is districts in England and how many patients are admitted to a stroke unit rather than a normal ward. And we know for definite that actually for this case that stroke units are much better for patients if they have a stroke. So we know good is being in the stroke unit and ordinary ward, not so good for outcomes. And this is based on service-based as well because we are looking at districts. The PCTs are population districts in a sense. So on the way here, some are 100% admitting into a stroke unit, so dark blue ones, and others are below 50, below 50%, around 40%, right at the other end. That's a huge variation. So we know sometimes some places, in some districts, patients are getting 100% of the best benefit. Yeah. Right at the end, less than 50% off. This is all within one country, and it should be mindful that this is a national health service in case of England. Okay. This is change for lower income countries, also very interesting. And this is like a population-based use of look on use. So we can look at a few things here. This is a use of immunization coverage. We can see that, again, there's huge variations. In some countries, some no data. The dark gray. But again, you can see that on a population level, you have huge variation in use. And population-based emergency admission rates to England for asthma. So this is not a referral, just a general turn up to emergency department for asthma. Huge variations. We can assume the prevalence and there might be some prevalence and variation in asthma in district. But if this is population-based admission rates, are we assuming that much of a difference within one country? Why is that? And we might ask ourselves. Okay, so when we're presented with data like that on utilization rates, what can we do? And actually, before we even get into that, it's important to consider a few things. Statistical factors is important to think about when you look at data. We know that sometimes data is incomplete. And so we always have to question the data. To make sure it's correct. Random variation can be statistical differences, chance, bias, confounding, and also, so that can explain some of the statistical factors. And so we can actually do something about those. Demand factors, we know there will be age, sex, population differences, and morbidity rate. illness behavior we talked about. That's fairly hard to account for. And then also supply factors, the availability of services and of professional judgment. Okay, so when people want to lower variation, there's often a belief that there's a hidden agenda, like, you want to reduce variation to the lowest level because that's the best. We can reduce costs. But actually, we don't know a lot of the cases, except stroke units, that whether or not the lower end or the higher end is better. For some things, it might be that we should be reducing things to the lowest of variation. So we need to think about different things. And then when we are seeing data, we might see that actually, when we want to know if people are reporting data in a way that's fair and also in a way that's transparent. Some places are underreporting intentionally because they know we want to decrease variation. Okay. Also, for supply side, we also know that there are differences in, so when there's availability of services, it's pretty standard, we can measure that very easily. We know that the professional judgment varies a lot between countries we've seen. How do we find out and adjust for these things? We just need to know, we need to know that actually, for demand factors, that there are some things that can be accounted for. But things like illness behavior and professional judgment is actually very impossible to capture. And a combination of things that we might need epidemiological studies, and that routine data won't be able to help us answer all those questions. Okay, so this is an interesting figure and statistics from America, just to show us the sort of variation we're talking about in terms of professional judgment. And I think this is a good example of the variation in services in use and what's offered. So we've got things that are very low variations, very nicely presented. Hip fracture repair. That's reassuring, isn't it? Because your hip is either fractured or not fractured. And you hope that all fractured hips will be repaired. So that's very low variation. This is each of the line is a region in the States or a district. All the way to the other end. Radical prostatectomy. Look at that variation. That's huge. That's I don't know from here. There's hugely divergent views as whether or not, and we don't know which of the district you want to be in if you have prostate cancer. Is it that you don't have a radical prostatectomy, or is it that lots are referred for radical prostatectomy? Somewhere in the middle is things like hip replacement, back surgery, bit of variation. But it's impossible to say. But it's very nicely shown. So what are we all thinking about now? The most key important thing is, does use reflect need? And how do those two relationships work? We see use, we see evidence of variation in use. We know that there's different elements of need. How do those two fit? And this is probably what we're really after. Probably in many countries, use probably doesn't reflect need. But it's how much it differs we want to know. Seeing this huge variation. And this is a GP in New South Wales, Julian Tudor Hart, in the 1970s, and he wrote this, which is really quite neat. In areas with the most sickness and death, general practitioners have more work, larger lists, less hospital support. They inherit more clinically ineffective traditions of consultations than the wealthiest areas. And hospital doctors shoulder heavier caseloads with less staff and equipment, more obsolete buildings, and suffer recurrent crises in the availability of beds and replacement of staff. These trends can be summed up as an inverse care law, he quoted and said. And that the availability of good medical care tends to vary inversely with the need for population served. So, what he's saying here, and it's probably similar in your country, and even today, we can see that the burden, the sick who need more care should have more care, but actually have the least. But the opposite is true. The wealthiest who need less care may have the best access and use, and also the best care for them. How widespread is this in London? Let's consider a couple of things. Birth, age. At birth, an elderly may have higher levels of need. And look at socioeconomic status, because we know poorer may have higher things. So these things we know, and let's have a look at the data. So this is a health expenditure for women in Netherlands, in Holland. And then they followed up on women throughout, and they look at this, and then you look at this and you go, oh, it looks about right. Age 0, you need healthcare, quite a little, because we know at birth, neonatal, intensive care, etc. You need some the first year of life. You may have childhood infections and you need care. And towards the latter, and this looks like it seems to reflect need. Then we have socioeconomic status from another study and the use of healthcare. Health visits to healthcare professional in the past 2 weeks by social status. So the top social class is 1 and 2, and then all the way to the most deprived, social class 5, we see that actually the most deprived have a higher visit and a higher visit to hospital and higher visit to health professionals. This also looks like direction seems to reflect need. Poorest, more hospitalization. This is GP referral rates per 1,000 people of a population. And let's look at this. The least deprived have less referrals, and most deprived have more referrals. This also shows us that actually use looks like it is reflecting need. Poorer, most deprived, have more referrals. But we must also want to ask ourselves, is this gradient steep enough? We know it's going in the right direction, but should it be even steeper? Should it be much lower for the least deprived and much higher for the most deprived? We don't know. Is it reflecting need well? To do that, we have to consider one more thing. The use-need ratio. It's necessary for us to consider the use to need to access to think about whether or not this higher utilization rates reflect the higher level sufficiently. Okay, so it's difficult to know true need. We can use a surrogate and proxy measure of need. And then we want to compare that with different groups of using the same service. And then we also need to measure the demand side factors like morbidity and illness behavior. So this is use-need ratio. Now this is interesting, understanding a proxy measure of need. Because we don't know the true need for coronary vascularization and the true need of coronary heart disease, this is a study that's done from my school at LSHTM some time ago. They looked at different districts of UK referral for coronary heart, back then there's CABG, so coronary heart bypass surgery for people who have a cardiovascular disease. And we don't know necessarily the true need of cardiovascular disease in all the districts of England, but they have used the proxy measure using the SMR, standardized mortality ratio. So on the bottom line, we've got standardized mortality ratio. And, we know that if it's above 100, the higher is worse, which suggests a higher level of need from deaths. And we've got on the top here the rates of CABG, and we can see that actually there is an inverse care law here, that in England, the districts with the lowest level of surgery have the highest SMR rates. Okay? So here, use is not reflecting need, okay? And where need is measured by proxy. And this is in England, which is very, it was surprising when this was founded. This is a system based on process equity Like we can see the inverse care law working here. Those who have the lowest level of surgery have the highest level of need. This is also interesting. This is from PROMS data. So in England, they do patient-reported outcomes for hip and knee, and they have found that those who are most deprived socioeconomically, in the 20% most deprived in the population, have more severe symptoms. The odds ratio, that's not odds. They have 3.6 points less in their score for severity. So they're more severe than those who are have higher socioeconomic status. So they were in greater pain, had greater symptoms at the point when they had surgery. We don't know anything about those people who didn't access healthcare. This is just at the point when they had their hip replacement. And also those people who are more deprived have 11% more likely to have a longer history of symptoms than those who are less deprived. And these are statistically significant. Okay. This is also another showing measures of type 2 diabetes and different processes by deprivation. And we can see that actually the trend is clear. Okay, when we look at measuring demand side factors, this paper is very interesting as they've tried and attempted by Canadian researchers to look at not only morbidity but illness behavior. And this was the first. It's so hard to measure illness behavior. So they took two areas in Ontario, which is one of the provinces in Canada, and they measured low use and high use areas. They have looked at objective data as well, so they examined them, x-rayed them, and looked at the need in the population as best as they could. So they found that actually in the low use area there was a population of 26,000 versus high use area. Then severity of arthritis does vary. So they did find that high use of hip and knee replacement areas have more severe arthritis than low use. So that trend works. But they also did the survey, which is the extra bit of trying to understand illness behavior, is asking them, do you want a hip and knee replacement surgery in their survey? And they also interestingly found that high use areas also want more surgery than low use areas. We thought we knew about variation in need, variation in disease prevalence, but what we didn't know before this study is measuring illness behavior is how the variation changes and how much people want surgery. And this is within one country, one province, and actually there's differences between how much people want surgery. Sometimes we might be criticizing for inequity. We're saying, oh, look, there's such a huge variation in use, such a huge variation. But actually, what we don't know normally is how much there's a variation in illness behavior and demand for that. Sometimes there might be a good explanation for a difference. People just don't want surgery. We are assuming that these people are given good informed decisions and making the right informed decisions for their treatment choice. There is differences. Okay, well, I went through all that, but hopefully that was giving you an overview. Thank you very much.